Turaga. He's a radiation oncologist. And generally when you think about appendix cancer, we don't quite think of radiation quite often. But I had the fortune of meeting Dr. Turaga when I came here. And his research in predicting metastases is remarkable. So far you guys heard a little bit about how the microbes in our body make a difference to cancer. We heard a little bit about how our own immune system tends to check it. But Dr. Turaga's work has been remarkable in trying to figure out how our own genes can actually help us predict how we think about cancer and how they actually can spread. In addition, he's also a remarkable individual, remarkable clinician, and so it's my privilege to introduce Dr. Turaga to speak to us today.
First and foremost, I want to thank Dr. Turaga for inviting me to talk today. This is a topic I'm really passionate about, and happy to explain to you guys the exciting work that we're doing here at the University of Chicago. The only disclosure is that based on the work that we've done, we've actually have a patent to use gene profiles of tumors to predict whether folks are going to have a better outcome or a less favorable outcome, and how to use those profiles to guide further therapy. So today I want to talk about two things. The first is to help you understand that when we talk about metastasis, that's a whole spectrum of disease. There's no one disease that we can call metastasis. It's really many different entities, ranging from a single metastasis to an intermediate state where there may be, say, 1 to 5 metastases, and then a state where there may be widespread disease. And really the underpinnings of those states is completely different. Secondly, I want to explain to you that by understanding the biology that drives metastasis, it will better inform how to treat these tumors and how to potentially cure more patients who have metastatic disease. So an overview of metastasis as we see in the clinic. First off, we know that unfortunately the majority of cancer-related deaths are due to metastasis, about 80 to 90%. And it really is one of the dominant challenges we have in treating patients. The main issue with metastasis is that when a tumor takes residence into a distant organ, it compromises the function of that organ. And ultimately, at some point, the organ is unable to function correctly. Typically, most patients who have metastatic disease are thought to be incurable because metastases tend to generally be widespread. They tend generally not to exhibit a few spots, a few locations. And most therapies to date are palliative in nature for metastasis. They do prolong survival and they do relieve symptoms, but by and large, we don't cure most patients with metastasis, and that's a problem. Some exceptions do occur, and Dr. Luke highlighted those, where some patients with melanoma, lung cancers, and some kidney cancers can be cured with immunotherapy, but by and large, we need better ways to predict who can be cured, how to integrate other therapies in addition to systemic therapies and immunotherapies, such as surgery or radiation, and how we can use the integration of those to cure more people. The biology of metastasis is very complex. It's one of the most complicated processes that occur during the development of the cancer. And metastases can actually develop when tumors leave the primary site and go to distant sites. They can actually develop from the distant site to another distant site. And sometimes they can leave a distant site and go back to the primary. It's very complicated. And this has been shown elegantly with a lot of scientific studies. But what we know is that the process of metastasis is very inefficient. So of the cells that leave the primary tumor, less than 1% of them actually can get to the distant site, take up residence, and grow, because there are a lot of factors that limit the ability of the tumor to grow in a distant site. Those include the turbulence of the bloodstream. That alone can be very damaging to tumor cells. By the time the tumor cell gets to the distant site, there's a host immune response that attempts to kill the tumor, and other factors like getting through the blood vessels and the lymphatic system is a big barrier for tumors. So it's a very inefficient process, and you can imagine that having such inefficiencies would likely mean that if a tumor has gained those abilities, it may be either very proficient, or if the tumor doesn't have all these abilities, it may be deficient and may only develop a few spots. And we're interested in who those people are that are likely to get only a few spots, and if you were to address each of those spots with like surgery or radiation, can you actually cure those people? And so what I want to press on to you is that metastasis is a spectrum of disease, ranging from single to a few to many. And this concept was really recognized here by Ralph Luxembaum and Sam Hellman about 30 years ago. And at that time, there was a huge debate about whether this actually exists. And clinically, we see it all the time. When folks develop metastatic disease, it's not always all over the place. It sometimes is limited in nature. And so this concept that was defined here as oligometastasis, oligo meaning few, suggests that for folks who develop a single or a few sites, they may require chemotherapy and systemic therapy, but if you were to address those singles or few sites of disease with surgery or high dose of radiation, you might be able to cure some of those folks. Typically, when you think about a local treatment like surgery or radiation, it's mainly used in the setting of metastasis as a palliative treatment. Most of the time, we use radiation surgery as not for cure in this setting. That being said, in some instances where we only have a single or a few sites of disease, we might be able to use those for a curative intent. But how do we identify who those people are that would actually benefit from the radiation or surgery? And that's the goal of the work that we're trying to do here. Based on our work, we propose that by integrating clinical factors and biological factors or genetic factors, we can predict who's likely to get only a few spots versus those who are likely to get many spots. And by using that information, we believe that we could potentially cure more people with metastatic disease. And this is a prime example of that. We recently studied folks who have colorectal cancer who presented either at the same time they had their primary tumor diagnosed or at a later time after their primary tumor was taken care of. We studied those folks who had about 1 to 3 metastases to the liver from their colorectal cancer. And the way these patients were treated was with definitive management of the primary, which meant that it typically involved chemotherapy and surgery and potentially radiation, and all of the sites of their liver mets were taken out. So every single site of visible disease was taken care of with a combination of therapies. And these patients had no other visible sites of metastasis. And what we found is that when patients were treated this way, a third of patients never recurred again. They were, by all intents and purposes, cured. And that curve is the blue curve at the top. At 10 years, almost 80% of these people were still alive. By contrast, about 2/3 of folks did have a recurrence, some of which could undergo re-operation to get rid of them. Some of them, it was too widespread to do that, and they were managed mainly with chemotherapy. And you can see that the survival for that group, shown in red, was about 15%. So we have a dramatically different outcomes for patients based on their ability to be cured with the local treatment of surgery. And our question was, what's the difference between these two groups? And can we use clinical and biological factors to predict this? So we recently published this in Nature Communications, showing that by integrating the DNA properties, the RNA properties, and the protein expression using a variety of sophisticated tools, we were able to decipher that even though patients appear to be the same in the sense of having only a few spots, they were biologically very heterogeneous. And what we showed for the first time with clinical metastasis was that there were actually 3 groups of metastases from colorectal cancer, that they were not all the same. And so I've summarized the 3 groups here, the first being what we call canonical. And this group made up of about 33%, or about 1/3 of the patients, and they were characterized by having a poor immune response in the tumor, very little stroma inside the tumor, but increased levels of proliferation. The tumor cells were growing very rapidly. And there were specific mutations that we found in these tumors, and Dr. Luke actually highlighted some of those in his talk, and it turns out that we found the same ones in these samples as having an association with a bad immune response. And interestingly, this first group, they were likely to, even after they had surgery, they were likely to recur in many places. But their outcome was intermediate. It wasn't poor, but it wasn't the greatest. By contrast, the second group that we defined was a highly immune inflamed subtype. This made up of about 30% of patients, and they had very high levels of immune responses, many T cells inside the tumor, and showed very specific mutations as well. This group had the most favorable outcome of the 3 groups. Lastly, a group that we defined as a stromal group showed a poor immune response as well, but due to a different reason. Not that they had proliferative properties like the first group, but they had a lot of stroma inside the tumor, and there was just a physical barrier that the immune cells could not get into the tumor. So you can see that there are different reasons why patients could have favorable or unfavorable outcomes. And if we knew these properties in advance, one could envision a scenario where you might treat someone differently had you known they were an immune subtype or a poor prognosis stromal subtype. And to that point, we asked if you integrate these variables with clinical variables which are known to regulate survival after surgery, can you predict who's likely to be cured? And we did that. And we found that there was actually a low-risk group who had essentially immune properties and favorable clinical factors, and the survival at 10 years was 95%. This was a group that we could cure, and they were cured, in fact. By contrast, there was a high-risk group where only about 15% of people were alive at 10 years. This group was unlikely to be cured with just surgery alone. And again, an intermediate group exists, a whole spectrum exists, and by knowing the clinical factors as well as the biological factors, we can predict who's going to be cured and who may need more intensification of therapy after the surgery. For example, the high risk and potentially intermediate risk group.
Can I ask you how many people are in this study?
134. And to take it one step further, when we looked at each of these groups, the low-risk group, which I've designated on the right graph as the left column, half of them actually did recur. So the surgery alone did not cure them, but they were able to undergo repeat operations. And when they recurred, half the time they did, it was always in only 1 or 2 or 3 spots. It was never all over the place. And so that's a striking finding, that if you knew that you were a low-risk patient, it may be feasible to go back in and do another operation to remove that site of metastasis because you were likely to be cured. Even further, the low-risk patients never recurred outside the liver. By contrast, the high-risk patients, half of them were typically recurred in the liver, half of them typically recurred outside the liver in the peritoneum, in the bone, in the lung, and sometimes in the brain. So they had other features about the tumor that made them a higher risk for extrahepatic or outside the liver recurrence. And that's a very striking finding. In terms of peritoneal metastasis, which is of utmost importance in this conversation, there have been some attempts to do similar studies, albeit not to the same degree. And what a study from Duke found is that for folks who had colorectal cancer or appendiceal cancer, who had metastases to the peritoneum, who underwent removal of all of these visible metastases in addition to chemotherapy, that there were actually differences in terms of the biological features of these patients. And they could use those differences in the biological features to categorize patients as low risk, i.e. cluster 1 shown in green, and high risk, cluster 3 shown in red. But you can see that the biological features may help determine who's likely to be cured with an operation, and they help guide where surgery may be useful as a modality on top of chemotherapy. And so there's a tremendous amount of work that we're doing here and that colleagues at other centers are doing as well. We propose that by using an integration of the genetic data and the clinical data, we can actually redefine how cancer is staged overall. That claiming a tumor is metastatic is meaningless unless you have further integration and subdivision of that grouping. And so we're proposing to use this information to help guide not only therapy, but stratification of folks with metastatic disease. Scientifically, we're trying to understand what's the relationship between the tumor and its host, and how do those interactions determine whether a patient has a better biological feature or a worse prognosis feature, and can we alter those? Dr. Luke alluded to some of the factors in the tumor that change the immune response. We're looking in the tumor as well as the host to understand how we can modulate those, how we can change those, and can we shift a poor prognosis subtype to a better prognosis subtype. Thirdly, we're trying to understand how do you integrate chemotherapies and immunotherapies and other systemic agents with localized therapies like surgery and radiation, and does one augment the other? Can you use radiation or surgery to make chemotherapy more effective or immunotherapy more effective? So we're doing a lot of work from that perspective. And there are actually a lot of trials right now trying to better understand, not only for GI cancers, but for lung and melanoma, how to integrate these two localized treatments and systemic treatments. And I think in the future, it's going to hold a lot of promise. And so what I want to leave you with is that 4 points. One being that metastasis is not one entity. There's a whole spectrum of metastasis ranging from single to widespread, and we need to better understand what distinguishes those features. And what I've hopefully proven to you today in the example of colorectal liver metastases is that some folks who have limited spread of their tumor to limited organs can potentially be cured with treatments like surgery on top of the chemotherapy. By better understanding the features that distinguish, in the perspective of clinical and genetic determinants, what determines metastatic spread, we're going to really do a better job of personalizing medicine for the individual patient by offering better ways to treat that person based on their genetic profiles. And I think taken together, these suggest that we really have the possibility to cure some folks with metastatic disease, and maybe we can expand that subset when we have better systemic therapies. But I think there's a lot of promise here, and we're really excited to share that with you.
The fact that, when we use the words like stage 4 appendix cancer, stage 4 cancers, that not all stage 4 is the same. I mean, all of them are different, and we're understanding these differences slowly. And I think from a patient standpoint, would you say, Sean, that if patients want to be kind of more involved in, both understanding about their own tumors, do you think like contributing to research is certainly one thing? Are there other things patients should be thinking about or doing based on what your work has shown so far? That
would be a tremendous help. Just to get this data was a tremendous feat from many institutions. The U of C, North Shore, Yale, Memorial Sloan Kettering, we all actually worked together to do this. And not only was it intensive from personnel, but financially it was a very big cost to get this. But I think it sheds light on and develops a foundation for how we should be thinking about these kinds of studies down the road. And by proving that this is relevant to other cancers, I think we're going to totally transform the way we think about metastatic disease and the way we treat metastatic disease.
Great. Thank you so much. Our next speaker is Dr. Misic. He is one of our gastroenterologists, and I've had the good fortune of cohabiting with Dr. Misic and Carol in our professional worlds. Dejan and Carol Semrad have been incredible for us. As many of you know, the process of having surgery, the process of going through a HIPEC can alter the way the bowels work. And I think for us to have someone like him with us in our clinic has been fantastic. And so we invited Dr. Misic to speak a little bit about the role of nutrition in oncology, both around surgery as well as in the general care for yourself. So thank you, Dejan.
Thank you to Dr. Turaga and the ACPMP for putting together a forum like this. Can everybody hear me okay?
Yeah.
Okay. So I think that, we can see that cancer is obviously a very complex disease process, and how many different types of providers that we have at this institution that can all play a small role in that's obviously to the benefit of the patient. I'm going to talk about something today kind of that's probably a very interesting topic for a lot of people, and we'll kind of highlight towards the end where we need to do a lot more work on this topic. But we're really blessed here at the U of C to have what's called a nutrition support team. It consists of 3 of us physicians. There's 3 dietitians, a nurse that specializes in vascular access, and then also a pharmacist. And we really focus on the malnourished patient. We actually also have some other interest in obesity as well. But the goal here is to talk about how nutrition can impact both cancer and surgical outcomes. So I don't have any disclosures here, but the outline is going to be to first kind of try to define what malnutrition is. This is actually a much more complex word than it really sounds to be. And then what's the role of a nutritional assessment, which is what we do in the clinics every time we see the patient. And then we'll flip the 2 topics at the end. We'll talk a little bit more about how we approach nutrition in people undergoing surgery and then also people undergoing chemotherapy. So what is malnutrition? Kind of a common definition is just when there's an imbalance in the nutrient intake and the nutrient losses or the calorie expenditures. And this can be affected by a lot of different topics. In the setting of cancer, there's an increase in cytokines, which actually blunts the stretch of the stomach, and it causes us to have a loss of appetite. This also happens in the setting of chemotherapy. And then people that have had surgery, particularly to their stomach, to their proximal small intestine, can have issues with absorption and absorptive surface area, so that there's areas of the small intestine that are unable to absorb all the calories that we're putting in. So there's malabsorption of calories, and then also there can be an uptick in the requirements of calorie support. So in the setting of undergoing a surgery, any kind of infections associated with surgery, simple pneumonia, in the setting of malignancy, there's an upregulated metabolic drive and an increase in the need to supply calories. So whenever we have a prolonged mismatch between calorie supply and demand, that's what can lead into malnutrition. What is malnutrition associated with? Well, this is just kind of some references, but really any kind of morbidity. You can think of this as any kind of things that can go bad, can be worse in the setting of a malnourished patient. Somebody coming into the hospital is going to stay in the hospital longer if they've had weight loss going into the hospitalization. They're more likely to come back into the hospital, and in the setting of HIPEC, there's one small study showing that they actually have an incomplete cytoreduction, so an incomplete successful surgery, more postoperative complications, and then also people undergoing any kind of chemotherapy will have increased mortality related to malnutrition. Now, in the slide that I just technically showed, we had various types of terminologies for what is malnutrition. Some people associated it simply with weight loss. Other people looked at CAT scans, and when there was a decrease in skeletal muscle, that was associated with malnutrition. So everybody used a different definition of malnutrition and associated it with some sort of morbidity. All I've said so far for the malnutrition definition is that there's an imbalance between supply and demand of calories. The problem with this type of a definition is that it's not very objective. There's not really a number that we can place to this or a grade that we can give to the patient as to put them on a scale as to who's more malnourished and who's more well-nourished. And so we're going to get into how we can get to a better definition, which truly we only have from last month. So there's been some studies since the early 1900s, but we've really only kind of come to a consensus definition recently. And that's probably one of the biggest drawbacks right now in nutritional support, but it's going to really pave the way going forward for some better studies. So when we look at just kind of traditional indices of nutrition, so weight loss, somebody that's unintentionally losing weight is more malnourished than someone that's able to maintain a weight. We've known these types of studies from, like I said, since the 1930s. And various studies have shown that people with weight loss have a poor tolerance to chemotherapy, unable to complete the cycles, or there's more complications with the cycles. Simply measuring skin fold thickness has been one of the markers of nutrition. So skin fold behind the triceps is kind of a marker of fat mass. Or the circumference of someone's forearm is kind of an indirect marker of how much muscle mass they have. These are not perfect types of definitions. Here on the right and the bottom, the accuracy of these to some kind of consensus statement of what malnutrition was, it's only 60 to 70%. So 20 to 30% of people will be characterized as being malnourished when we measure just their mid-arm circumference. And people are using other kind of more sophisticated techniques these days of measuring fat using bioimpedance or with CAT scans looking at the muscles along the spine. And then the last piece is it'd be really nice if we just had a blood marker of what is someone's nutrition level. And I think a lot of people have heard what albumin is. Albumin is a protein that's synthesized in the liver. We take in protein and then it's broken down into amino acids, goes to the liver where our own body can synthesize proteins. The problem with albumin is it's affected by a number of different variables. How much protein we take in, how quickly that albumin is being degraded. In the setting of inflammation, it's going to be degraded more often. So despite giving people 150% of their calories, really kind of force-feeding patients, even through an IV, the albumin number necessarily won't change. The patient's no longer malnourished when they're getting the calories that they need, but some of these indirect markers are not changing. So we need some better markers of how to measure nutrition. And so that's where people have tried to kind of put all this together and say, okay, let's take weight loss. Let's take how much the person is eating. Let's take their overall disease state and put it into some sort of lump sum. And this was done in the 1980s. It's called the Subjective Global Assessment from Canada. And it really took a number of different factors. And the problem was this was actually a paper in one of our highest impact journals, New England Journal. And it took them 5 years to publish this figure, which is how they actually measured it. So, and then the problem is actually it's in the name. It's subjective. So everybody, there can be a difference between the graders, who's calling somebody malnourished and who's not. It's graded as A, B, C. But the good piece here is it actually takes in a lot of factors. It takes in weight loss. It takes in their overall intake. If someone's been losing weight, but then they stabilize over the last couple of weeks, they actually get an improved grade as opposed to the person that's continuing to lose weight. So the problem here is that this is actually very time consuming. It can take 10 to 15 minutes per patient if we try to do this on every patient that's admitted into the hospital. So what a lot of people have done is since then is they've created these kind of overall scores. 1, 2, 6 question screens to say, let's highlight this person. They're maybe more likely to be malnourished. So we can apply other screens like the Subjective Global Assessment to a more defined population. So all these other screening tools are now utilized, and we use these types of tools to screen patients in clinic for who's more likely to become malnourished so that we can intervene upon them early. This is probably one of the things that's really lost in medicine is using these types of screen early on as opposed to once a patient's already lost 20% of their body weight. So we've gotten into a nice piece on kind of how we can overall measure malnutrition. There's pluses and minuses to each of the individual traditional indices, but if we kind of combine them all together, we can get a better general assessment of someone's nutrition status. But I still haven't really gotten into a clear definition, and that's really because there wasn't a consensus definition between the American and the European societies. We tried to take various factors like is seen in that Subjective Global Assessment, like weight loss, decrease in overall muscle mass, but the societies were not able to fully agree on what should be kind of the gold standard for a definition. And we can see between the American Society and the European Society, one of the big differences is the European Society it considers a low BMI associated with malnutrition. That doesn't exist in the American population where there's the increased prevalence of obesity. The problem with that is somebody can still have a heavy weight but be malnourished. absolutely no muscle mass. In the setting of inflammation, the body actually preferentially targets the proteins to break down our protein stores before it's going to break down our fat stores. And so people can be, and by protein stores, this also means diaphragm, heart muscles, so that people can have, that's where malnutrition can lead to increased morbidity. So now this is literally published a month ago. We have kind of a consensus definition between the American, European, Latin American, and Asian societies saying let's take one criteria from each of these sides: weight loss, low body mass index, reduced muscle mass, setting of a chronic disease or decreased food intake, and then we can grade this on a moderate, severe scale based on how much weight loss they've had. This now is going to allow us to all speak the same language in the studies so that we can all use the same type of criteria and get even larger studies on board. So what do we do here in the Regional Therapeutics Program? We try to identify malnutrition early, and then from a clinical standpoint, we're also studying what is it really related to. Very few studies out there specifically look at peritoneal malignancies or cancers that can target the peritoneum. So so what we're trying to do is look at what are the morbidity that's associated with the malnutrition in this specific population. Ultimately, then we can have a marker to study even further, and we can try to apply nutritional interventions, either oral intake, supplemental oral intake, or even IV intake of calorie support. So when it comes to overall surgery, we've talked a little bit about weight loss. Weight loss has always been associated with a poor marker of outcomes in surgery. And I love this graph from, is in 1936, because you know that the surgeon was sitting there with a stencil and a pencil, and you can only imagine us doing that kind of stuff these days, but it highlights the point perfectly, that a 20% weight loss before going into surgery for a gastric ulcer really is a nice cutoff point where people had either a 30% chance of mortality or a 3% chance of mortality based on how much weight they lost going into surgery. So since we know that weight loss is associated with poor outcomes, we also know that nutrition is really important in helping people have a reduced length of stay and a reduced length of complications. This is what's considered the enhanced recovery after surgery approach. This was really developed in colorectal surgery, where we try to decrease the time that the patient is fasting before surgery, increase calories given even relatively early before surgery, and also immediately after surgery in select cases so that we can reduce the time that the patient is going fasting. That's associated with a reduced length of hospital stay and also with reduced wound complications. The one problem kind of with overall nutritional support studies is that they don't necessarily highlight the patients that are highest risk. And this goes across kind of the nutrition studies in general. We can't just simply supply calories to everybody across the board because there is this gradient of who's malnourished and who's not. So now that we can select for the patients that are more likely to have complications due to malnutrition, we should be able to create studies that really target that high-risk population. We've had to try to kind of combine studies, so a combination of 9 studies showed that taking in 500 extra calories, that's basically 2 cans of Ensure, 20 to 30 grams of protein per day for 2 weeks before surgery is associated with a decrease in hospital stay of 2 days. Associated with that, exercise is actually also important, so 30 to 60 minutes, 3 to 4 days per week, all going into surgery to prevent that immediate postoperative complication. There's actually an older study from the 1980s, I believe, or early 1990s, where people at highest risk in the VA population were given IV nutrition support for 1 to 2 weeks, and they actually had a decrease in postoperative complications. When it comes to cancer, malnutrition has got a high prevalence in cancer, and it's all due to those pieces that we already talked about. Increase in burning of calories, decrease in consumption of calories, and certain deaths in cancer are specifically related just to nutritional support. Why does cancer affect nutrition? Well, we've already kind of mentioned how it reduces overall calorie intake. Obstructing cancers also will reduce calorie intake because we simply can't get the calories in. There's an increase in the burning of calories, and then also it alters the physical activity of the patient so that there's a preference for the proteins and the muscles to be burned first for easy calories. So what kind of interventions can we have in the setting of cancer? Well, really, probably one of the biggest interventions is simply meeting with a dietitian to talk about how to get more calories in. What are the ways to get additional calories into the body, either via tubes or even IV lines. So identifying malnutrition early and initiating some form of calorie support is associated with a stabilization in the weight. And we've already seen kind of what the problem is when people are having already weight loss for both chemotherapy and in undergoing surgery. The problem with nutrition right now is that we don't have any great studies telling us that just simply giving nutrition is going to overall improve survival. But I already said it's a very heterogeneous population and heterogeneous types of cancers. We're not selecting for the patients that are either going to be the most likely to be at risk for nutrition or for malnutrition, or for those that are already malnourished. So what kind of things should we also look in and add on? And this is, I think, kind of a relatively hot topic, is are there additional things that we can add to the diet to overall help even survival? So fish oil supplements, 2 to 4 grams per day, have overall been associated with increases in lean muscle mass and improvements in appetite. These are small studies, 30 patients in the first one, 90 patients in the second one. But this is something that I actually kind of talk a lot about in my general GI clinic, which is an idea of going towards more of a Mediterranean diet. Decreases in saturated fat, increases in the monounsaturated or the omega-3 fatty acids, increases in nut intake, olive oil, 3 cups of coffee per day are okay. And in a study of colorectal cancer, people with stage 3 colorectal cancer, those that ate more than 2 servings of nuts per week actually had an increase in survival long term. This is over 800 patients from Yale. So these are the types of things that we have to take into account. What is the patient's anatomy? Are they able to tolerate these types of things? Fats get absorbed in the small intestine in the more distal locations. But are these any types of interventions that we can add to help people through both chemotherapy or surgeries? These are the types of things that obviously are going to require a lot bigger study, because these are still relatively small studies when we're thinking about cancer in general. So just to kind of conclude, I hope I was able to get the point across, which is how bad malnutrition can be, and sometimes actually how under-recognized it is. We can try to intervene upon this early to help support people through both chemotherapy and through surgery. And now that we actually have some form of a consensus definition, we can all start speaking the same language and on a kind of a research standpoint, so we can have multiple centers participating in similar studies. Nutrition intake before surgery, so 500 calories 2 weeks before surgery, protein intake before surgery, exercise are all associated with improvement and less complications after surgery. And although we don't have quite as strong of studies in the setting of just cancer and chemotherapy, maybe there is this idea of immunomodulating formulas or the good fats to take in to help us through chemotherapy. Open up at that point to any questions? Thank you, guys.
Thank you. So are we all eating tree nuts and fish oil for now?
You know, it took me almost like 2 years of practice before I finally kind of started implementing it even for myself. But yes, now I think I've kind of said it so often that I half a pound of nuts is kind of that little container that you see at the grocery store on the checkout line. So I always try to kind of pick those up at least once a week. Olive oil, about a tablespoon a day. We actually have the same recommendations in our fatty liver clinic in heart disease. So I am making a little bit more of a shift, even personally there.
And do you think, like, a lot of our patients will come in with supplements and they'll try vitamins, things like that? What are your general stands on things like that?
So overall, I mean, I think that these are things that we also have to just measure in the clinic so we can see what people are deficient in. We always take into account what, if they've had surgery, are there any deficiencies that they might be at risk for? So intestinal resections, proximal, anything that's on the periodic table that can be at risk for not having enough of. So it's simply just taking a vitamin every day. I do think that there is some benefit to vitamin D. I didn't really touch about that here, but we are all deficient in that here in the northern latitudes. So I think simply a vitamin D, multivitamin, and then I think particularly just calories. Calories and protein is really what's needed going into something like surgery. These types of fish oils and all that, obviously I don't think there's much harm to them. There's a little bit of a bleeding risk, so we would have to talk about that before surgery. But outside of those, I wouldn't put much weight into a lot of the things that people are looking up online either, though. That kind of stuff needs a little bit more study too.
Great.
Just one simple question about peanuts.
Peanuts.
Peanuts is not free, so
Yeah.
is that included in
The ones that have the most kind of monounsaturated fats would be almonds, almonds, pecans, and I think it's cashews. So those are the ones. I always kind of push the almonds one actually. That's the one that has the most beneficial fats.
Great. Thank you so much. You know, hearing all this nutrition stuff has made me hungry. If you don't mind, we'll move lunch up a little bit, but before lunch, I wanted to see if we could get one talk in. I think this is one of my someone that I'm really excited about. Dr. Toon is one of our palliative care physicians. I think what I have really benefited from having Dr. Toon in our clinic is using her as a supportive oncologist for me. So for many times when our patients walk into our clinics, we're really just talking about the cancer, the chemotherapy, the surgery, the radiation, but I forget to ask about how's your pain and how's your nausea and how are you feeling and what are your emotions like. And I think that's where it's been incredible for us to have Dr. Toon with us, who really kind of helps balance us and treat all our patients as true human beings. So welcome, Sandy.
Thank you. Okay. Hi. So thank you so much for the introduction, Kiran. So as you mentioned, my name is Dr. Sandy Toon, and I am a doctor of palliative medicine here at University of Chicago. So the title of my talk, as he introduced, is Supportive Oncology in the Case of Patients with Appendix Cancer. I wanted to make a clarification. So as you can see, I am a palliative medicine doctor, and so I wanted to point out that supportive oncology and palliative medicine are two terms that refer to the same type of specialty. And I wanted to talk more generally today about how palliative medicine can actually be very helpful in the care of cancer patients. So we'll talk about that today. So I have no financial disclosures. And so my objectives are to define for you palliative medicine, differentiate palliative medicine from hospice, because oftentimes when I first walk into a room, as Kiran mentioned, people will ask me, are you the hospice doctor? So I want to clarify that. And then I also want to define the role of palliative medicine within a cancer team. Okay. So the question always comes up, what's in a name? So there are many terms that are used for what I do, and it really does depend on the institution and depending on the clinic that you may meet one of the specialists. So supportive oncology is often used, palliative care is used as well. I tend to use palliative medicine mainly because our accredited national board tends to refer to ourselves as palliative medicine. Okay, so people will ask, what is palliative medicine? So this is the definition from the actual website of my American Board of Palliative Medicine. So it's a board-certified medical specialty. I'm a physician where we focus on improving a patient's quality of life, and we do that by managing pain and other distressing symptoms of a serious illness. And so this can be provided at the same time that you are getting other medical treatments. So I'm often seeing patients at the same time as they're seeing their cancer specialist, their surgeon, oftentimes as they're seeing their other specialists as well. So people often ask, is palliative medicine the same thing as hospice? And I will bring up that as part of my board specialty, I am specialized in also doing hospice, but it's usually not my focus when I'm speaking with people. So to clarify, hospice is specifically talking about end-of-life care only, whereas palliative medicine, actually, you can start at the time of diagnosis, and it's really the full spectrum of care from there. So hospice is really a subcategory of palliative medicine. And so that's something that I always like to clarify when I'm meeting people for the first time. So people will ask, what's the role of palliative medicine in my medical care? And Kiran has done a great job of introducing already, where we will focus on symptoms and quality of life discussions for people with serious illness. So let's take a closer look at that. So what symptoms could a palliative medicine doctor address? So oftentimes what I'm doing is I'm meeting with people, talking to them about their pain, their nausea, also about their bowel habits as well, and seeing how I can help them with their constipation, talking through appetite as well. And then the other big part of this, I think, is mood, talking about anxiety, depression, because that plays a huge role in how your body is really coping with treatments, coping with the diagnosis. So that's a big part of what I talk about as well. People often will ask, what do you mean by quality of life? And so I further define that by saying it really comes down to what your values are and what sorts of treatments you do and do not want based on your values. So a lot of times when I'm speaking with patients, it's understanding what's important to you, what kind of functionality in your life is important for you as well. So thinking about quality of life also, that's also including discussions talking about planning for emergency situations. So oftentimes another big part of what I do is talk to you about advanced care planning. So we'll talk about advanced directives and we'll talk about code status as well. So has palliative medicine helped others? That's something that people will often ask. And so actually there was a 2010 study done at Harvard. There were over 150 patients at that time. So this specifically had to do with non-small cell lung cancer. And they actually introduced palliative care early on. So they would actually have people see palliative medicine folks at the same time that they were seeing their oncologist as well. And they found from that patients, for patients with the new diagnosis of the metastatic lung cancer, that early palliative care involvement actually led to significant improvements both in quality of life and in mood based on the surveys that they did as well. And now you may be asking, but will palliative medicine help me? And so I would argue that my specialty, palliative medicine, we're really looking at a holistic view of patient care. So in addition to helping people out, talking about all of the symptoms, we really want to get to know you. And one of the things I'll bring up to patients and their families is that you are so much more than your diagnosis. And we really want to be able to honor that and be able to meet you where you're at. The other thing I bring up is that oftentimes we talk about this battle for cancer. We talk about it as a war on cancer. And people will often tell me, this is my battle and I'm fighting it. And one of the things I bring up is that palliative medicine is, consider us to be another ally as you're going through your battle. So I would say that as you and your family are going through a very difficult time, we're another layer of support. So thank you so much for hearing me out. Any questions? Yes?
So what does your typical day-to-day look like?
Do you mean for like an appointment?
Just in
or?
terms of, like one day, what is a typical day, like meeting with patients and that sort of thing?
So I work in both the hospital and in the clinic as well, and so oftentimes I will get consults throughout the day in the hospital where I'll meet with patients and families. We'll focus on what specifically I can help them with, whether it's symptoms, whether it's talking more about their goals of care. And then usually my half days are also in clinic as well. So on Tuesday afternoons, for example, I'll come in and see patients as well. So oftentimes patients will come in, they'll talk with Dr. Turaga and the rest of the team about the cancer treatments, surgery, they'll talk about nutrition and physical therapy as well, and then they'll also meet with me to talk about kind of where their goals are right there. That's a great question.
Great.
Sounds good, thank you so
Thank
much.
you so much. Carol Cope and Jennifer Bernal. I know you guys are all here with the families. I've known both of them for some time now and I've been incredibly touched by both of you and both your stories. So thank you so much for coming today to share them. And like I said, please remember, there's a lot of people in this room who are going to learn from what you guys say today. So thank you so much for doing this.
Well, we do anything for you. You have to excuse me because I have notes or else I go off task. My name is Carol Koch. I am a 26-year retired principal and school teacher. And about 7 months after I retired, I wasn't feeling well, went to the hospital for an appendectomy. And I said, take it out. Fine, I don't need it. Well, things changed. So it was at that time I was diagnosed with appendix cancer. And it was very strange for me because I was asymptomatic. And my appendix had perforated and had sent the cancer all over my stomach and areas for about 2 years. So by the time we got to it, it was a little bit more extensive than just taking my appendix out. But talk about life can change in a moment. If you would have told me after all my years of being in symposiums and presenting that I'd be sitting at this and paying attention, I would have said there's just no way. But life did change in a moment. And at that time, we quickly got the family together. We talked about a strategy. There was no anger. It was not, why me? It was, why not me? And what are we going to do about that? So I have a huge support system that you're gonna see, and very lucky to have that. So we set about doing research. I have a sister who's a nurse, I have daughters who are more tech savvy than I could ever be. And we tried to find the research and realized there's not a lot out there, that we're really a chosen few. And so we tried to make the best decision possible, and I went to MD Anderson. And no one that I speak about is to say that any of these doctors or these locations were bad, because they're not. They're wonderful. But it's like in education. It's finding the right fit, the teacher to the child. When I would make class lists, it's will this child function really well with this teacher or with this parent? It's about finding that individual need. So at MD Anderson, we did chemotherapy, and then I went in for a laparoscopy, because I'm one of those real fortunate ones that the only way they get to see if I'm doing any good is they have to go in. So consequently, I have like the map of Chicago on my stomach. And anyway, they went in at MD Anderson and determined I did not fit their protocol for having surgery. Not only then, but in the future. I was off the list. So we said, okay, we got it. They told me kind of to go home. And I think the worst part of it was how that message was delivered to my family and how it was delivered to me. And we decided this is not a good fit. So we went back home and we started more research. Dr. Rayani, who is my oncologist from the University of Chicago at Silver Cross, where I live, said to me, there's a number of great physicians out there, with Dr. Turaga being one of them. So we set out to come up with a list of questions and interview surgeons across the country. And I'm blessed because I was able to do that. Not a lot of people can do that. So we were in Washington, D.C. You can only imagine who I spoke to there. We were on the East Coast, another wonderful doctor. And then we came back to see Dr. Turaga. And Dr. Turaga, when I told him what we were going to do, he said to me, I am honored to be on that list of physicians. And that if you do not choose me, can I please follow your case? And I was really moved by that. So we interviewed him from questions on what kind of care are you going to give, as well as do you have a belief in God? That was important to me. We need to leave our egos at the door. I learned that a long time ago as an educator as well. So we stayed with Dr. Turaga, and we've never been so happy to do that. He uses whiteboards, so that tells me he understands there's different learners out there. And you know, when you're a patient, and those of you who are patients, you can meet with your doctor 10 times and you hear it over and over again, but you gotta hear it over and over again. Because I don't know about you, but I space out. They give me a point, and all of a sudden my mind is going somewhere else. So Dr. Turaga, I think, understands that. He will answer all of our questions, and he has a great sense of humor. So some of the things that we really appreciate about Dr. Turaga, okay, is that he listens. He doesn't just listen, but he listens, and he answers your questions. And I think he cares. He must care about me a lot, because I've been to every person on the team, from the nutritionist to palliative care to physical therapy to the psychiatrist. And I didn't need any help, so I'm fine. The whole team. So what it tells me again is that he's treating me as a whole person. Oh, oncology as well. So I have 2 oncologists. So I've got a double blessing. He is kind, and he's interested in research. Previously today, we heard one of the doctors say that he's never met anyone who is so more active and involved and engaged in finding a cure for this cancer. And he is like that. And I think that's what continued to bring us to him. That we knew he cared, he was going to think outside the box. Other places don't think outside of the box, and he's willing to take chances and risks. And those of us who are on this end want those chances and risks. We're willing to do it. I'm all in. You just throw the stuff at me, and I'll take it. So One of the cute things that he did is after my first surgery, my whole family, you know, all 96 of them, were waiting for him to talk to him, and he was kind of on his way out, but he pulled a chair because he knew this was going to take time, and he sat down and he talked to them, and he answered their questions. The other thing was, he said that during my first surgery, because of what he saw, it was more of a film, okay, he consulted another colleague, not on what to do, but what do you think? So he phoned a friend. Thought that was pretty cool. I thought the fact that he was willing to share that with us showed me that he left his ego at the door, and that he was willing to go to other people and tell me he goes to other people. You didn't know this was going to be a roast, did you? I feel very special. He also does this for me. I am a huge Luke Bryan fan. I'm a huge Luke Bryan fan. He plays the music for me when I'm going into surgery. Now, I don't think he's playing it for 8 hours. I think he shuts it off. But he puts me at ease when I hear kick the dust up, and I'm going under, and I'm feeling good. So I appreciate that. He not only takes care of me and my family, but he's created this team. And he has educated or been involved with getting his nurses, the nursing staff, the receptionists, everyone at the university has been so kind. I have never met such a great group of people that are always willing to help. And I think that has to do with the directive and the climate, you know, at the University of Chicago, and certainly Dr. Turaga. When I, I gotta turn the other side. See, that's why I need paper. I think one thing that cancer has taught me is humility. I'm a very kind of aggressive person. As an administrator, you have to take charge, you have to make decisions, and all of a sudden, everybody was helping me. And that was, you have to be humble and accept everyone's help. But I'm learning. And I do appreciate it. So we sat by and we talked about what's next. So being at the University of Chicago, the big thing that I heard through all these doctors today was what I'm so passionate about, and that is collaboration. You know, in education, if we didn't have teachers talking to teachers and parents, we were learning in little snippets of time, and we were pigeonholing our knowledge. And here at the University of Chicago, you can see how they collaborate. You can see the people, you pull in the best. You get people to talk. You get 4 eyes are better than 2 eyes. I used to tell my teachers all the time, come tell me what we need to do. And I see that here in this climate, let alone it is, as Dr. Turaga said to me once, this is the University of Chicago. I go, okay, I got it. So you could tell that he has a pride in being here. And I am very happy to be here. I'm very pleased with the care that we got. Cancer affects not only my life, but it affects all my family and my friends. And that's hard to watch. But the team here helps a lot, and we get through it all. The cancer community is way beyond the bricks and mortars that we have here. Is my time up yet? Okay, keep going. And it's lucky for me, even though I'm pretty involved in technology. Never had a Facebook, I have one now. Never had a webpage, I have one now. I have a daughter who's into that. My other daughter is into so much research. She's a social worker. And they have all taken on different roles. My son, my daughter, my sisters, my friends. And what we have found is that not that you guys don't give us a lot of information, but it's the community outside of the hospitals. Because those Facebooks and the one that you run, Treese, people put out a phrase, and there is an answer. I would call my daughter in Virginia and go, my hands are turning brown. Can you figure this out for me? Because I don't want to do that. She'd go on the sites and, Mom, that's common. Don't worry about it. I'm constipated. Have a Coke, Mom. Okay. That's fine. But that information that comes right from those who are living it or have lived it or been caretakers is so huge. So those Facebooks, the PMP, the ACPMP has been completely so valuable to us. I cannot express that enough. And I thank you guys for keeping that going and helping all of us out there, because when we first started with the lack of information out there, we were pretty dumb. And 18 months later, we're getting pretty smart. To the point that, we can answer questions and we can offer suggestions because we've lived it. So we feel like we're giving back to those who gave back to us. So that is just huge. So during this diagnosis, of course, after the first week I thought I was going to die, so what do? I'm a planner. Life insurance, everything's ready. All right, I'm ready to go. And I found these flowers, these glass ornamental flowers that I had seen in our travels, and I decided to start making them and giving them to friends and family and engraving them. And so that's what we did, and we came up with forever flowers. And it was just for them. And all of a sudden, something exploded. Friends wanted them, the story got out. I was on Facebook, and one thing led to another. And we today have been making these flowers. That's Jen. That's how Jen and I met. We had one of our open garages, and Jen brought her entire family to the house where we could sit down and talk about this type of cancer, because you don't know a lot of people who have it. In fact, 95% of the people, when I tell them, I go wherever I go. Do you know, I went for a shot the other day at Walgreens, okay? Do you know I have appendix cancer? And I said, and I'm not telling you that because I want you to feel sorry. I want you to know that there's appendix cancer. And these are dialogues you have to have with your physician sometimes. And because if not, you don't hear about it. So we, to this date, we started 18 months ago. I was diagnosed, February 2017. And we have had open garages. We have Facebook, 1,500 Facebook followers now. We've made a total of 1,700 flowers. We've donated out of my garage, not a lot, but $37,000 to ACPMP. Some of the money last year was given, went towards a grant to a doctor in Paris. We have been seen on ABC, and so has Dr. Turaga. In fact, it's on his page, okay, to get the information out there. In fact, twice they came out. We'll go to the next one. And what started in Illinois is now across the country and throughout Europe. So we learned how to package glass flowers. That's not easy. And sometimes we lose a few. But people, once they hear the story, they want them. And they've taken them to Italy and Germany and other places, and we just keep going. We put little square, little copies of this on the table for people, because this is our information packet that we hand out to people to know our webpage and to try to promote what we do. We asked people to send us pictures from their gardens, so we could see and we could share what they're doing with them. So those are just some pictures.
I have 8.
You have 8? Yeah, Teresa's in my garage. And here's what my thought was. When I look at them in the sunshine, they glitter and they make me smile. So I thought if that could be a positive, lasting memory, that would be a good thing. But what has happened to this is something that I did not expect. It's not about the flowers. It's not about the donations. It's about the collaborativeness of the people who tell their story. Or send me cards, even on the Facebook, or when they send me their payment, They send me cards and letters thanking us because it helped them through the grieving process. It helped them remember those who they lost. Or they want one made for their daughter-in-law or their children because it will remind them of their father. I did not expect that. So on days when we're busy, and I think, oh, we're going to keep doing this, we keep doing it because it is fulfilling a need out there that I never anticipated. So that's part of my garage. We've had to rewire the whole place. And luckily my husband of 43 years built shelves galore. And people come and shop and we keep producing them. It's a family affair. My grandchildren, my son, my daughter, we make bets with my son because he's never going to sell. But they do. And people have contacted us and said, you know, my mother died from cancer, can you do a pink one? And it's just amazing what this has helped people with. So we're very proud of what started out to be something small and private into something that has helped other people. So this is just probably a tenth of our supporters, and those are mostly my children and my grandchildren and best friends and other family members, and they're all in their garbs when we're selling that day because we help them to the car and we give them poles and we do all this stuff. And after 18 months, I feel more blessed than I ever was. So thank you, Dr. Turaga, and Jennifer's next. So. Okay, so I could do. Oh, thank you. See, he's a hugger.
It helps. It helps.
It helps.
I too have notes. But thank you, Dr. Turaga, University of Chicago and ACPMP, for allowing us to tell our story. When they initially asked me, I couldn't tell my story without Carol, because as I go through my story, you'll learn that I never would have found Dr. Turaga if it wasn't for her and her girls and just finding this community. So I'll go through kind of my history and where everything kind of started for me. And it actually started with getting married to my husband. Next one.
Oh, backwards, sorry.
Yeah, there you go. So in 2012, we got married. He's pretty wonderful and funny. And I better say handsome because if I don't say handsome, I'll probably get it when I get home. But in 2012, we got married, and soon after, we started thinking about building a family. And in doing so, we had some struggles. We went about a year or so before we realized that we needed some help. So we reached out to FCI and Dr. Feinberg. And we went through the standard procedures. Nothing really stood out. We did a hysterectomy just to give me a better chance in hopes that with an IUI I'd be able to become pregnant. And after I had that surgery, I had felt a pressure in my bladder. And we couldn't figure out what it was. We ran numerous tests, nothing came up. And then also around that time, I was gaining weight. And I figured I was stressed out, maybe my hips were telling me it's time to bear children, and I wasn't eating anything crazy, but I just chalked it up and focused on us getting pregnant. So we did an ultrasound before my first IUI, and we did a round of Clomid, and it didn't take. So after that, they run another ultrasound just to make sure you're clear. And that's when the ultrasound tech wasn't able to see my organs, my reproductive organs and organs surrounding that. And that was the first indication that something was wrong. So from there, Dr. Feinberg had referred me over to North Shore, who helped with diagnosis, and they ultimately sent me over to Loyola. And this was right about the year of 2015 or so. So in that state, I think as a lot of people in this room can attest to, you're kind of in a state of fear. You're looking for answers, and what referrals and little information that you can get, you're trying to act on it. And so right after I met with Loyola, I went ahead and I made the appointment for the surgery. So the surgery took place in, I believe it was October 30th, 2015. And when I had awoken, I had taken out about 15 pounds of tumor, 6 organs, and I had removed everything reproductive as well. And the time leading up to that surgery, I have to say, my mind was not in the appendix cancer arena. My mind was still stuck on fertility because I was thinking about it for so long, for 2 years leading up to that, that after I had my surgery, I was like, you know what? We're gonna be okay. We're gonna be able to save something, and we're gonna be able to have our kids. And so I didn't do myself the service of really taking the time to research what I was in for. And if I could go back in time and take it all, I wish I would have had the mindset to switch. So when I woke up, I had breathing tubes, I had feeding tubes. I was actually tied down to the bed, and that was a moment I was like, I had no idea what I was getting into. So at Loyola, I was there for, I think it was 2.5 weeks, 4 days in the ICU. And the recovery, I think, was pretty standard. The one thing that was difficult about it was I had an ostomy. And the ostomy had extended my recovery period from 3 months to 6 months because we didn't realize how it had actually taken away from the nutritional value that I was trying to put in my body. And so literally my body was slowly dying because I couldn't keep anything in. And we didn't realize it until later on. And by that time, thank goodness, in March we were able to get it reversed. So soon after that, it was reversed, I was feeling great, and I was on my way, right? So and then we started back on the fertility journey. About a year later, which we're now into 2016, we had scans that it had come back. So at that point, we had learned that it was now on the outer part of my left lung. And that piece was a little bit more important than the abdominal area. There were small pieces that were there. So at that point, Loyola had referred us over to UPMC with Dr. Sarkaria and Dr. Bartlett. So we made the trip out there. They were able to remove almost everything with the exception of a small piece that I still have but is pretty stable. And it was a great, like Carol said, all these doctors in hospital, like, they're great. They know what they're doing, and fortunately I had a great experience with them. So now, at that point, that's when I had gone through 2 surgeries, and in my mind, I'm like, there has to be more information out here. There has to be more people experiencing what I'm going through. Whether it's cancer, it's fertility, it's side effects, it's these symptoms that I'm feeling. I need more information, and that's when I actually came across ACPMP and the Facebook group. And it was, I mean, when I say the doors opened and the flood of information came through, that's an understatement. I was able to make immediate connections with everybody and all the information. It was relatable, it was understandable. Therese, maybe you don't see a ton of posts from me, but I'll tell you every symptom, anything that I experience or anything I'm looking into, I do a quick search on that topic, and there's already 20 posts, and there's already information out there. I don't have to go out there and put anything new, and that is so valuable to me. And then same thing with ACPMP, all the events, the information, like all you guys are doing to spread awareness. And ultimately, that's how I found Carol. And Carol had her first garage event, and that was the picture that she put up on her presentation. And I was able to learn a little bit more firsthand, because she was the first other appendix cancer patient that I met. And ironically, so it was posted as Lamont, Illinois, and I was like, this is like Lamont, California, or Lamont, England, or I was like, there's no way this is in Lamont, Illinois. So I was so excited that you were only like 20 minutes away. But, so I met with her. Family, as open and beautiful as you see her today, is the way that she and her family greeted me. And we soon started exchanging stories, and that's when I first learned about Dr. Turaga. And in the level of care and hope that you had instilled in her came through to me. And we knew that we had to do the next abdominal surgery. And I was like, you know what? I want to partner up with somebody. There's a ton of skilled and experienced and talented doctors out there. I wanted to find the right one for me, right? So at that point, I made appointments with University of Chicago, with Edwards. I think we had, at that time, we had reached out to Northwestern was starting a program, and Dr. Turaga was the first one that we met with. And we went to the appointment, me and my husband, and we sat down, and in comes this army of people. I'm like, wow, this is a big event. And one of the things that I appreciate, that I just, is my first memory of you, is he busted out the whiteboard, and he did a diagram of my cancer specifically. And he put it into relatable terms that was easy for me to understand. And not only did he go over my cancer, but he went through all the different types and where I kind of fell in line. And even doing something as simple as that gave me perspective and understanding of what I was dealing with. And I thanked you. I think I thanked him so much that he looks at me, I don't know if you remember this, he looks at me and he says, he's like, why don't you know this? He's like, you should know this. And then at that point I realized, I was like, he's 100% right. I'm like, why didn't I know this? Why don't I truly understand this? And from that point on, that's when I felt empowered to go out and really understand it. And so I have to thank you for that little moment, because that changed who I was as a patient. And so with that appointment, we were so impressed with the team from nutrition and loose, and I think you sat down and you gave me all these pointers of how I could change my current diet, and what to look up, whether it's nutritional drinks, proteins, all types of stuff. We walked away with a slew of information. Physical therapy, so they sat down, or they laid me down. At the time I had a scar, and it was, I believe it's called keloid, right? So it was pretty thick and pretty bad, to the point of where physically it had pulled me down. And so I wasn't a patient of University of Chicago at that point. They sat down and they started massaging my scar, and it was painful. But I didn't know that. Like, I had no idea. And knowing that the psychology team was there too, I walked away from that appointment learning more in that hour than I had done at any other appointment with any other doctor. And so at that point, we got to the garage. We're like, we're pretty sure we're going to Dr. Turaga. And we did. We went to one other appointment just to be sure, but we left there. We're like, no, let's call Dr. Turaga and move forward with him. So at that point, we had it was May 16th, and ironically, we actually we were in the hospital together.
We were twins.
And it wasn't planned, it wasn't, anything like that. We weren't trying to line up schedules, but it worked out,
It did.
right? So with that surgery, I asked Dr. Turaga, and I said, if it's at all possible, could you please not give me an ostomy? Because the experience that I had before, I was recovering for 6 months, it was the worst. I was petrified of going through that again. And I probably asked you 100 different ways, begged you a million different ways, and he was so kind each and every time. He listened to me, he let me just get it all out there, and he, with a smile, he would say, he's like, I'm gonna do my best. He's like, I hear you, I'm gonna do my best. And when I went in for surgery, I remember I woke up, and one of the first things, when I saw you, one of the first things he tells me, he's like, did you put me to work, girl? He's like, I redid all your connections, your small intestines, your colons. He's like, but you have no ostomy. And that, my heart was just overjoyed and happy. You listened. I felt like a person at that point. I felt that you had listened to me and you were taking any measure that you could to grant my wishes, you know? So, and I can say that my recovery too, because of that, I know I've had the best recovery period in all of the surgeries that I've ever had. So I thank him for that, for sure. But one of the reasons that we, like Carol had mentioned before, one of the biggest reasons that we decided to go with the University of Chicago and Dr. Turaga is because you are looking for solutions outside of your standard debulking and high-pack. There's so many other options out there that he's trying to pull from, and we weren't hearing that with any other facility. And that inspired a lot of hope in me. You know, I was just telling you, we were joking about it just a second ago. I'm like, whatever care you need to put in place, you know, these surgeries, they gut you like a fish. If we could avoid gutting me like a fish, hey, sign me, I'm all for it. I'm your girl. So I appreciate that, you know, just going outside your standard box. And I just realized I haven't even looked at my notes. I don't even know where I am. But the other thing too, I need to thank the nurses. I need to thank Janie and Dr. Lane and Dr. Sue. While I was in the hospital and thereafter, they were they would listen to every complaint I had, every care I had, any outlandish request or symptom that I had out there, and they were right on it. So it means everything to us. And I can't ask for anything more. And then also, I was really lucky to have you in the hospital too. We were looking after each other, and the distraction from what you're going through. I want to make sure she's okay. She wanted to make sure I was okay. I think our families were just going between rooms. We were only, I think, 3 or 4 rooms apart, something like that. So it made it pretty easy. Yeah. So, but here's the thing is, when I thought about what I wanted to say and the point that I wanted to make, I think there's 2 groups that I'm speaking to. And one is the patients, right? And what I want the patients to take away is that there's a huge community out there. University of Chicago and Dr. Turaga, they're building that foundation in that community. But like I said in the beginning of my story, I didn't have the patient community, right? When I found it later on and I had decisions to make, that community was so vocal that it solidified and validated what my heart was saying in going with Dr. Turaga and the University of Chicago. So there's resources out there, reach out to patients, check out the websites, the groups, all of it, it's there for you. And what we think as patients matters. It does make an impact. The other thing too is the lesson that I learned from you, understand your cancer. Understand, educate yourself. It's one thing to lean on the doctors and to get information from them, but you gotta do the work too. So those are my 2 tips that I wish I would have, from the beginning, that's what I wish I would have done. And then the other side of it is the professional. The medical side of it is, so we see you guys for 10 minutes at a time, at appointments, before or after surgeries, and we probably run through 100 questions in our mind over and over and over, and by the time we get to you, we probably repeat ourselves over and over and over. But the patience that you guys take in listening to us and answering us means everything. We're holding on to every word you're literally saying with every fiber of our being. So just taking that human aspect of it to listen to us, we go home with hope. We go home with just feeling good about where we are and what we're doing and who we've decided to partner with. At the end of the day, I just want to be a wife. I want to be a daughter. I want to be a sister. And one day, I want to be a mom. And I know that putting my life in his hands, and aside from my life, my hopes, my dreams, I know I'll be there to be a mom one day. And that's all I could ever ask for out of this whole thing. And to make some really good friends along the way.
Thanks.
Yeah. And so, sorry, that's where I get emotional.
So you got no choices, you gotta save us all.
But, you know, a huge thank you to you, of course, to your team, to especially the families. You guys go through it right there with us, whether it's having makeshift picnics in hospital rooms, long visits, and just the support at home, and we couldn't do it without you. And it's not only family, it's friends, it's work families. My work family has been amazing in supporting me, allowing me to keep my job, allowing me to get well, you know. It's a community, and I just, I can't thank all these people enough. But thank you for giving me this opportunity to be able to speak my story, and hopefully it helps. Hopefully it helps somebody. But,
Do you want me to turn mine?
I forgot about my slides. I was so emotional.
Do you want me to at least go through them?
Yeah, this is my family. These are the faces that you guys probably saw on a daily basis here at the University of Chicago. And this is some of the pictures while I was in the hospital.
Jen? Sorry.
Oh,
Okay.
thank you. But yeah, some of the pictures and family members. Oh, and this is my niece and nephew. They had me laughing all the time. Although you know how kids, they get into everything. The gloves, the whatever, and they were gonna fix me, and so that kept me laughing.
Oh. Future doctors.
My future doctors.
Thank you so much. Thank you both.
Oh, you're welcome.
Thank you both. I think we're coming to the end of the event. You know, it's always. I have to tell you, when I was a second-year resident, I told you that story. The other thing that had changed my life was when I actually went to an event where Gabriella Graham, who's of the PMP pals, actually came out to an event like this and spoke about her story, and it really gave me sort of pause on how we did things and what we did things and what we said. And so I hope what you guys both shared your stories today inspire all our trainees and our team. So I think to conclude and get to the end of this, I just wanted to introduce this army or this team or this group of people that you've heard about consistently in some of these stories. I'm incredibly grateful to all of them over here. I have literally dragged them to come and speak over here, specifically Jamie. But I think it's really nice for you to hear a little bit about who these folks are and what they do. So with that, I'd like to introduce Luz, Janie, Lauren, and Emily, if you guys want to come on up, and then we can start.
I'll do introductions real quick.
Hello, my name is Emily Fenton. I'm the physician assistant with the regional therapies team. My name is Janine Trevino, and I'm from the school regional therapies team.
And I'm Luz Chavez, I'm the oncology dietitian for the team.
And I'm Lauren Mansell. I'm the physical therapist. So we actually had a great introduction actually by our patients. So I was like, oh my gosh, they can actually explain what we're doing. So we are part of Dr. Turaga's multidisciplinary team, and actually a very integrative approach to providing services. I'm gonna go with my notes too. So our goal is to really evaluate and optimize your treatment-related impairments. So we are looking at your physical function, we are looking at your nutritional status, your social well-being, and your quality of life. We operate, here at University of Chicago, our program has access to, comprehensive, very, very comprehensive specialized care. And we'd like to really highlight GI nutrition, supportive oncology, our psych-onc, and our medical oncology. Our team provides prospective surveillance, and what we mean by that is when you come in, we have a bunch of different eyes that are looking at you, providing a level of where you are at that moment, and we are looking to prevent and identify and prevent any problems that may occur during your treatment. In this surveillance, it is very multimodal. So we are watching you and we're looking at your medical concerns, your physical and activity status, nutrition, and importantly too, access to clinical trials. So this schematic represents how our workflow is in our clinic, and it's kind of funny because it looks kind of linear, and anyone who's been to our clinic knows it is circular and people are coming in and out, and we're trying to maximize your time. We're also really careful to see where you're at with getting the information. We know this is very overwhelming when you come into our clinic, and that at times we also kind of need to get paperwork ready and do a follow-up call or talk at a different time. So it's a funny schematic and it's great. It does show a breakdown of all of our duties and what I don't know if that's a great slide actually because it's kind of small, but it's so circular. And what makes this clinic so different is you have an embedded physical therapist and an embedded dietitian that is yours for using. And we are so supported with our PA and our nurse. We're so supported. It's very important. As a physical therapist, my job is to evaluate you in multiple realms. I'm looking at your physical strength, your endurance, your coordination, your sensation, your scar and or wound. I'm also looking for lymphedema. That's when any of your lymph nodes have been removed or they've been irradiated, and there's a special type of swelling that occurs with that. And also your pelvic function. So any bowel, bladder, sexual concerns, we have treatments for that. On your first visit, you are getting a baseline evaluation. Then you're going to be prescribed an individualized home exercise program, and you'll get a rehab packet. So you should be going home with a nice little packet of information. So even if you're a little overwhelmed by what's going on that day, you have a reference point. And finally, this is an example of a home exercise program. Everyone's getting a walking program. We want minimally 30 minutes of walking, and that could be 30 one-minute walks, 60 30-second walks a day. Minimally, we want 30 minutes of walking. We want to get you up to 30 continuous. My usual suggestion is going to Target, because you can use that cart for balance if you need it. I see it's perfect. The red labels at the end. 83-cent stuff you don't need. But a walking program is huge. Everything on our list, you do not need equipment. You can do the exercises we give you, you can do without any equipment. A stair program if you have stairs in your house. Sit to stand is one of my favorite it's very functional. It's core strengthening, and it's called closed chain. So I love sit to stand. I've been making a small, I've talked a lot about this exercise, and it's the silliest thing, coming up from standing and then sitting. It's a great exercise. Single leg balance, we do a lot of modifications for this depending on where the patient is at baseline. So you guys know in clinic I'll put you at the sink because that sink has a nice little handle, and I'm usually standing behind you getting ready to grab you because everybody knows that you're a lot of paperwork when you fall. So the single leg balance is very, very important. Deep diaphragmatic breathing, 5 minutes of that big belly breath, we know can help you in your autonomic nervous system and help you heal better. It can also help with potentially reducing any risk of adhesions from your abdominal surgery too, increasing that. And then there's a transversus abdominis isometric, little tummy tightener. I always say when you wake up from surgery, you can do your deep breathing and you can do that belly button tightener exercise. So with that, I'm going to hand over to Luz.
Hi, so once again, my name is Luz Chavez, and I'm the oncology dietitian for the program. Earlier, Dr. Mitchik did an amazing job kind of outlining the nitty-gritty details about nutrition and essentially kind of what drives me to try to help my patients. But ultimately, my role is to help prepare you for surgery. Really, my goal is to try to reduce that risk of malnutrition that was mentioned earlier. And, it's not only reducing the risk of malnutrition before surgery, but it's really through all of the phases of surgery. While you're in the hospital, after when you're discharged, and even a few months out. I'm still through email at least once a week, every couple of weeks, still communicating with Carol. So it's through the whole cycle. Now, being that dedicated dietitian to the program, this really allows me to individualize my care for you. Whether that means helping you gain weight, whether that means just cleaning up your diet a little bit, like Jennifer had mentioned earlier, but it's very individualized to what you are going to need before the surgery and kind of what happens after the surgery as well. Now, when you pair this, nutrition intervention and it's paired with physical therapy, it improves your strength, which also can improve your tolerance to the procedure. Like mentioned in Dr. Mitchick's presentation, it can reduce your length of stay up to 2 days. Clinic, during our clinic visit, I do address, barriers to taking in nutrition, but not only barriers for the patient, but also barriers to the family. A lot of family members don't always understand the complications that maybe cancer can bring in terms of eating, and, they push food and, try to help their family eat, but I'm also there to help them and give them techniques on how to, be there for their family member while they're going through cancer. Now, as mentioned before, my dedicated role really helps kind of target these barriers that you're experiencing before and after. But ultimately, my goal for my patients and their family is to reduce the anxiety that you have and any kind of discomfort that you have that involves eating as well. Okay. And with that being said, this is Janie, our nurse, our glue to our program.
Hi, my name is Janie, and I'm a little nervous, so my voice may be a little crackly, but I'm the nurse for the Regional Therapies program here at the University of Chicago. My role is to provide the patient with a bridge of communication between myself, between you, and between all the providers and the rest of the team. I'm typically the first point of contact for the patients, as I'm just more accessible to you guys, to our patients, and even to other collaborating providers. At the time of visit, when the patients come to see us, I'm usually the first person that they meet prior to everybody else. And at that time, I do give them a little overview of what their visit for the day will entail. I let them know that not only will they meet our physicians, but they're also going to meet with our physical therapist, our physician's assistant, and our dietitian. Some patients may also meet one of the members of our research team if they are here and interested in participating in any type of research study. I also provide patients with education on their pre and post-op care, as well as education on signs and symptoms that they may be having post-operatively and when to notify me soon before the symptoms get worse and result in an ER visit or an admission. As the first point of contact for all our patients, I do make sure that they have my direct number. And I just really encourage that they call me as soon as possible if they have any questions, symptoms, concerns. And this just helps for me to evaluate how they're doing, how they're progressing, and if I take that information and I give a recommendation, and I will send that message to the appropriate member of our team. If it's anything that has to do with, patient may say, oh, I'm having multiple episodes of diarrhea, for example, I can recommend an over-the-counter medication, but then I can also shift that message to Luz, our dietitian, who can also help with additional pharmacological recommendations or dietary recommendations. So communication is very important. It is key to maintaining a proper recovery and avoiding worsening symptoms. Another part of my role in the team is to make sure that I coordinate your care. So that includes, coordinating everything that is required for you at our visit, scans, labs, appointments with collaborating providers, and also part of that goes with like research lab, like I coordinate with the researcher too. And the importance of this coordination is to just make sure that everything is in line for you when you come to the visit, so that you make the most of your time there and your care team has all the information required to make sure that you leave at the end of the day with a proper plan of care for you. Thank you.
Hi, so my name is Emily Fenton and I'm the PA with the group. So as a physician assistant, I'm a clinician, so I help participate in creating medical decisions for patients. And so in clinic, what that means is I'm there seeing the patients, helping formulate a treatment plan based on their medical histories. And all of this is done in collaboration with the physicians that we work with there. So you'll see me in clinic, you'll also see me in the hospital. So if it's determined that a patient is appropriate for surgery, then I'm there in that hospital stay as well during admission and every single day that they're in the hospital. And so I'm following through with that patient each day, making sure that their recovery is going well. I also have operating room responsibilities as well. So what that means for patients is that I'm really there at every step of the way through their journey of care. And I think that's really important to have this comprehensive role. I am new to the program, but this helps me be familiar with each patient. And so when changes come up in their history or in their health, it's easy for me to see that because I know these patients. So I think that helps me with really facilitating, I didn't switch to my, there we go. Being able to identify issues as they come up and address those quickly. So one way that I might do that is by communicating with the team, and you've heard that we're all in constant communication with each other to make sure that whatever issues are coming up are being fielded to the appropriate people and addressed efficiently and wholly. Something else that I add in my role to the team is flexibility and availability. So that may mean after a clinic visit, if there were tests that we ordered, then we're following up with the patient with a phone call, and I can talk to the patient, explain what those test results mean, and make sure the patient really understands what's happening with their care. Another instance might be after they have this major surgery and they go home, I want to call them a few days after they've left the hospital and really check in on them and make sure that they're doing okay. Another instance that may come up, perhaps Janie will reach out to me and let me know that a patient is having an issue that perhaps is a little bit more urgent and needs to be addressed in clinic. Maybe we don't have clinic until next week. That's really not a problem because I am flexible. We can bring patients in outside of clinic hours and address those issues up front and make sure that they're really getting a lot of eyes on them and a lot of close follow-up. Of course, we're also available by email. We're available by telephone. Really, that's all of us that are participating and making sure that patients are doing okay every step of the way. So what we've seen with that, I certainly think that positively affects outcomes for patients. I think patients feel connected because of this approach, but I think a sort of measurable effect that we see is that we have reduced ER visits, we have reduced readmission rates. So one kind of simple example might be after a major abdominal surgery, very commonly we see patients not eating maybe as well as they could or drinking as well as they could, and they become dehydrated. And if caught early, that's easily addressed. We can set them up in our infusion center. They come in, they get fluids, they feel better, they go home, and they continue on their recovery. If allowed to escalate, that could easily lead to readmissions, and we simply just don't see that with our program because we really do have a lot of eyes on our patients. The next concept that I'd like to sort of wrap up with is the idea of survivorship. And this is sort of
wonderful problem now that we're seeing with our patients who have gone through this traumatic diagnosis of cancer. They've had treatment, they've had major surgery, their body looks different, and now they're on the other side of that. And they're coming to us in clinic, and now they're expressing new problems to us. Maybe they've been anxious for weeks about what their scans are going to show today, or just still dealing with sort of the emotional burden that comes with this diagnosis and everything they've gone through. And so it's sort of become an increasing passion of mine to pay attention to that and make sure that we're addressing those issues by being a resource to our patients as well as connecting them to resources. And not only our patients, but the family and their caregivers that have gone through that with them. So I think overall with all of these things together, we've really seen better outcomes for our patients and much higher quality of care, and we're very proud of that.
That was perfect, and I wanted to thank you, Therese, Lauren, and the whole ACPMP for helping us put this event together today. I wanted to thank all of you who took the time this morning to come and listen and participate. We're also available, so after the event, if you go home and you have event suggestions, or you feel you want to follow up on some research that you heard today, or you want to give us suggestions for how things happen, please feel free to email us. And finally, I wanted to thank Fujita one more time for putting this all together.